tympanic membrane, which is quite painful. I've had it done a few times from ear infections, and literally the last ear infection I had it over a whole weekend, and honestly, by Saturday night, I wanted someone to actually kill me. I mean, I was literally saying someone should just please just kill me, put me out of my misery. The whole head was just on fire, so not good memories. But obviously, the tympanic cavity and membrane do actually heal from that area, so there is some healing involved with that. Then you have to worry about scar tissue and loss of hearing when you have that as well. So you do have a bony wall separating the middle ear from the inner ear. The wall has two membrane cover openings, the oval window and the round window. And we're going to talk about them extensively here in a second when we go to the inner ear. And then we have the auditory tube. This is the passage that connects the middle ear to the upper throat. So yes, there is a connection for that. It's the eustachian tube, right? So middle ear infections often result from the infections spreading from the throat through the auditory tube. All right, so you end up with a throat infection to start, and then it moves to the ears. It's usually closed, but yawning allows the air to move through the tube. And of course, that's when you're going to equalize the pressure on the side of the tympanic membrane. So if you've ever been on an airplane, you've had this occur, right? You get a change in cabin pressure. You have to even that pressure out because now the pressure on the outside is higher than the pressure on the inside. Normally the pressure on the inside is a little bit higher to keep that tympanic membrane taut and actually responding to sound waves. But once that pressure changes, you have to open that eustachian tube up.
Or like,
which,
I was gonna say, or like going down the hills too.
Yep, any sort of pressure change. Going underwater more than 5 or 6 feet, you should start to feel the pressure on your ears as well. So, auditory ossicles, those three tiny bones in the middle ear, the malleus, the incus, and the stapes. So the malleus is attached to the medial surface of the membrane, resembles a hammer. The incus resembles an anvil, and then the stapes kind of looks like the stirrup of a saddle. It has a disc-like foot plate fitting into the oval window, and this is the conversion area. All right, this is where you're going to get those sound waves coming in. They're going to hit the tympanic membrane, and really what the job of these bones is take that, convert it, and to transmit it, right? So they're basically conditioning the signal, they're amplifying it, and making sure that the waves inside the cochlea are actually going to be strong enough to send that electrical signal. So you're going to vibrate along with the eardrum, so the stapes moves in and out of the oval window, initiating pressure waves in the inner ear fluid. Two small muscles restrict the ossicle movement during loud noises. So you have the tensor tympani, which is attached to the malleus, and you have the stapedius, which is attached to the stapes. See this here in a second, right here. So we've got our auditory ossicles, we've got our bones. This is our first bone, second, and then this is our conversion right here. So this bone is going to basically move in and out of the oval window, and that's going to cause pressures in the fluid of the inner ear. And then of course you have muscles that are going to, basically the muscles are here to do what? They're not here to help the signal move along. They're there to basically stop over movement, right? So loud noises, the noises are too loud, you can get an overpressurization of these bones in the tympanic membrane. So these muscles are basically here to stop them from moving so much.
Are there any tendons?
Well, what does a tendon attach? What does a tendon attach what to what? Muscle to bone, right? So those should be small tendons, right? You should have a connection here. And of course, ligaments would be bone to bone. And the tympanic cavity in the back, and then the auditory tube or the eustachian tube going down to the upper throat. Again, we have the malleus, the incus in the middle here, and then of course the stapes at the oval window. Actual size of these bones, incus, malleus, and stapes, will fit all three of them easily on the back of a penny. And so again, listening to loud noises on a constant basis can definitely do some damage to those bones, which are very small. Inner ear, labyrinths within the patries part of the temporal bone. So basically you have this little labyrinth filled with fluid. You have the bony labyrinth, it's a maze-like space in the temporal bone, filled with interstitial fluid. And then you have the membranous labyrinth, it's membrane-lined, fluid-filled tubes within the bony labyrinth. This is where those receptors are going to be for both hearing and equilibrium. And it contains endolymph, similar to intracellular fluid, and it is rich in potassium. We're going to see here in a little bit why the potassium is so important. Of course, as you realize already, I'm sure from what we've seen with both the eyes and the neurons, you're going to need a lot of ions moving around to convert that mechanical wave into an electrical signal. Inner ear is composed of three main regions. You have the cochlea, that's going to house the membranous cochlear duct. The vestibule contains two sac-like membranous parts, the utricle and the saccule. They are unconnected and positioned at right angles. And then you have the semicircular canal that contains membranous semicircular ducts. What does all of this look like? Inner ear. Kind of a maze system, right? So we have the cochlear duct coming in. This is where your sound is going to come in and create these waves. You've got your utricle, the vestibule, the saccule, the ampule. Don't worry about all this stuff, all right? I'm not going to ask you to go ahead and label these pictures, especially for the ear. The only ear picture you would have to label, and I'm sure we've already seen it. I hope we have. It looks like this with middle, the outer ear, middle ear, and inner ear. And there's actually, and I'll show this to you here in a bit, there's actually a worksheet. Otitis media. It's infection of the middle ear. It's most often experienced by young children. Basically what's happening is the eustachian tubes are not either very well placed or they just don't open very easily. And so you end up with horizontal, short auditory tubes, which gives those bacteria in the throat a lot more access to the middle ear. So of course they move up. They have a very nice open area to work their magic, and they basically multiply way too much in that area. Mostly ear infections are caused by respiratory infections, which spread through the pharynx, in through the auditory tube. And instead of air, then you get that fluid accumulation in the middle ear. You get pressure, pain, definitely reduced hearing, because that's one of the first things you notice right away is the muffled sound coming in instead because of the fluid. Of course, you can just evaluate it with, basically they just look in there, right? They can look in and look at the tympanic membrane and see whether or not it is inflamed or not. And it may require a myringotomy. What is that? Tubes in your ears. So they'll literally put a small opening in the tympanic membrane so that when there is fluid building up there, it just is able to leak out and you don't get that pressure building up as you would in something like this. So here's an otoscopy. Yeah. I got the second word though, photograph. I can say that. So as you can see, normal tympanic membrane, very easy to see through, kind of clear. Anything that's going to be basically very red and inflamed is going to be a middle ear infection. That's pretty easy to pick out. Anyone can pretty much look at this and see that you have issues with a tympanic membrane. So, hearing. What exactly is hearing? Well, the cochlea, the snail-shaped chamber of the inner ear. Basically, what you have is you have again that mechanical sound wave coming in, and it is moving those bones. The bones are moving in that window, and you are creating waves within the cochlear duct. You have a thick sensory epithelium consisting of hair cells and supporting cells on the membrane. So those hair cells are the receptor that are going to release the neurotransmitter to the neurons. All right, the hair cells have many stereocilia, or long microvilli, so basically cilia, and then one kinocilium at their apex. This is kind of like the main hair on the inside. They're both embedded in the tectorial membrane of the cell, and then the base of the hair cells are going to synapse with those sensory neurons. And the cell bodies of the sensory neurons are located in the spiral ganglia. Here we go, a little bit better picture of that. So again, vestibular membrane, the basilar membrane, so this is where those cells are embedded. And then basically what you have is you have the fluid coming in, moving these cells with the hairs, and the movement is what's going to cause that exchange between the physical sound wave and then getting converted over into the electrical message. Yes.
As far as the ganglia goes, what exactly is that? So I was reading, because there's a central system in the.
Ganglia basically means it's just a Latin word for body. So they use a lot of.
So in the ear.
Yeah.
Spiral ganglion.
Basically just those bodies of those neurons again.
Oh, okay.
So they're just using it as a body word.
Okay.
So the cell bodies of the sensory neurons are located in the spiral ganglia, which basically means spiral bodies.
Okay.
So this is the picture we should focus on when you look at what you are literally seeing when you hear things. Is again, you have this fluid moving in, and the hairs are literally going to wave back and forth, and the movement of the hairs is what's going to cause the signal to be sent through those neurons. So the sound wave to the nerve signal. The sound waves are going to vibrate the tympanic membrane. The ossicle is going to vibrate and transmit the waves to the oval window. The fluid pressure waves in the scala vestibuli push the vestibular membrane, causing pressure waves in the endolymph. So basically, now we have fluid waves. Specific regions of the membrane move, depending on the sound wave frequency. You can have high, medium, or low frequency sounds. Those hair cells distort, causing changes in the neurotransmitter release. Sensory neurons with axons in cranial nerve number 8 are stimulated to fire, and the pressure is transmitted to the scala tympani and absorbed by the round window. So basically, it's going to pass all the way through, as you can see here. All right, so what's happening is, again, sound waves. So you have those mechanical sound waves coming in, mechanical motion. You get this conversion now into a liquid wave, which is going to flow through. It's going to cause the cells to basically move. And now you have to get rid of this wave, basically. So it's going to have to leak out and then basically escape through the round window at the bottom. So there is an entrance way in and then an exit way out. So that's why, again, it's important to have this tympanic membrane or tympanic area behind there be air-filled and not fluid-filled, right? Because if it's fluid-filled, we're not going to get rid of those waves. They're just going to come out here and, again, move the tympanic membrane. So whenever you have that ear infection, that's why the hearing is going to go down, because you are filling this area with fluid, which should kind of mess up with the last step or the escape of the pressures. The remaining pressure waves are transferred to the outside through the round window. And that's basically what the round window is there for. It's just an area to get rid of those waves as they go through. So as you can see here, along the inside, we have our cells, and we should have a slide that talks about the conversion. There we go. So the hair cell stimulation, the inner hair cells contain ion channels at their tips and the tip link proteins that connect them. Hair cells are bathed in potassium endolymph that is far more positive than the fluid inside the cell. So we have a very positive outside and a very negative inside. When the membrane moves up, the hair cells are pushed into the tectorial membrane and their tips are tilted, pulling the tip links, or those proteins that are connecting them. The tip links pull open an ion channel, allowing potassium to diffuse into the hair cell, and that causes depolarization. The hair cells release more neurotransmitter from its base, exciting the sensory neuron, which can fire action potentials. When the basilar membrane moves down, the process quickly reverses. We should have a slide right here that kind of shows it for you. So the microvilli are connected by proteins. And it's the movement of the villi and then the proteins that's going to open these potassium channels. And when the potassium channels open, the potassium can flow in, and you get a depolarization, which is basically going from what? -70 to negative 40, right? Just like we saw for eyes, right? We saw negative 40 as our transition point. Yes.
So are the potassium channels the little purple things on top of the microvilli, or where exactly?
No, these are the proteins, the linking proteins, the tip links.
Okay, so where are the channels?
These are actually right here they're actually in this membrane.
Oh, okay.
And I know they kind of put it up here. I'm assuming, yeah. So as you can see, this protein here is kind of connected right to the gate. So the gate's probably, I'm assuming at the top tip of this dot here. So again, a lot of potassium on the outside. When you get a movement, the gate's open, potassium can go inside. You get a depolarization in the cell, and then the cell is going to release neurotransmitter to send that signal into the brain. So the perception of sound is created by pressure waves of vibrating objects, right? So vibration pushes molecules which transfer the energy from one molecule to the next. Here's an interesting question. Would it be possible to create a weapon to disorientate people using sound?
Oh, yes.
Yes, and they actually have done that. They have these very large cones that are able to push out very low frequency noises. And I've seen that they're very effective. It's basically going into an area. Have you ever been in a car where they have both windows kind of down and then one person rolls their window up, and it's usually in the back, and you get that pressure? That's exactly what that is. And so of course, if you have a machine that can and is able to push out those low frequencies very effectively, you could disorientate people very easily just with sound waves. The pitch depends on the frequency of the vibrating object. The frequency is the rate of vibration in hertz. Hertz is basically cycles per second. So we can hear anywhere between 20 and 20,000, which of course, as humans, we're awesome. That's really great. But most animals can hear actually way higher frequencies than we can, including birds, dogs. Sight is number 1. Hearing would have to be number 2. And of course, we already know sight is very limited for us. We know that there are waves around us that we do not detect. And of course, sound is the same as well. So we are looking at a very limited stretch when we talk about being the frequencies we're able to hear. Variations in pitch are detected due to variations in stiffness of the basilar membrane from the oval window to the cochlear apex. High frequency sounds are going to excite the cells in stiff basilar membrane near the oval window, and the low frequency sounds excite cells in the flexible basilar membrane near the apex. So again, when you're talking about frequencies, you should see here, you have to go further in for your low frequencies. Your high frequencies are going to be right here by the oval window, medium in the middle, and then your low frequencies are going to be all the way near the end of the apex. So they have to travel the furthest. Yes?
I was just going to ask a pressure wave and a sound wave.
Well, a pressure wave could be both through the air and fluid, where a sound wave could be both. It travels in both easily. Actually, sound travels better underwater than it does in the air because it's able to be carried further. So basically what you're talking about is just an interruption of the atoms. So it could be either air or fluid. It should be the same thing. So waves shouldn't really matter what kind of medium you're in, as long as the waves are large enough. So as you can see, our low frequency here are 20 hertz or kilohertz. Really low down here, and of course, you have to go way in for that. Of course, at our high frequency end at 20, it's going to be right up there at the open. This is going to depend on wave amplitude, the degree of molecular compression, right? So louder sounds create larger movements in the membrane. Larger movements cause faster rate of nerve signals and a larger number of stimulated cells. And of course, that's going to send more signal in, and then the temporal lobe is going to have to interpret that as loudness, right? So basically, the more cells you move at the same time, that's what's going to tell the brain what is loud and what is not. And of course, that's measured in decibels. So 0 decibels is basically a threshold for hearing. That would be no sound. And of course, energy of sound increases 10 times for every 10 decibel increase. So decibels end up, and there should be a, no, maybe not. I was going to say there should be a decibel table on here, but I guess they don't have one. Usually they include one. What's about the loudest you should be able to hear without hearing protection? Any ideas?
Talking about hertz noise?
Yes.
85?
Is equal to what? Standing near a plane when it takes off. You're supposed to be wearing hearing protection for that. 120 is where you start to see extensive damage, and that's loud music basically, or a chainsaw, or a gun firing. So all three of those things, they say, are definitely not good for hearing. And of course, it's not, oh, I stood near a speaker and my ears are ringing. That's not really what the damage is, right? It's an incremental damage. The more and longer you do it, the less you're able to hear because those cells become desensitized to all of that movement. All right, the brain. Stimulated hair cells are going to initiate signals in the cranial nerve number 8, the vestibulocochlear nerve. Fibers ending in the cochlear nucleus of the medulla oblongata. The secondary neurons transmit signals to the inferior colliculus of the midbrain or the superior olivary nucleus. I don't expect you to know where any of this is. All right? Pictures always help. There we go. So basically you've got ear sending in signal, and then you have your interneurons, and then finally you're going to end up in your primary auditory cortex, which is usually to either one side or the other. Now, normally, when you look at the brain, and I haven't really talked about the brain yet, I've kind of been saving that as the last chapter, there is a right and a left side, and normally what you see is redundancy. So you would see these same areas, but we only use the one side. We're not really trained to use both or the other side until you absolutely have to, right? So if you have a stroke or you have some sort of physical damage in the brain, it is possible to retrain the brain to do certain things, but now you would have to use other parts to accommodate that. So normally in, say, a stroke situation, the left side is the side that's going to be damaged. And so then you have to literally retrain the brain to start to access the right side. And that's what's so hard. It is possible, but it's very hard to train the brain to look in different areas. And that's really what all of the training is for, especially after those types of injuries. All right, deafness. Any sort of hearing loss is deafness. Of course, really, do you know that you're going deaf?
No.
No, unless you wake up one day and you can't hear, then that's a pretty good sign. But otherwise, really what you're talking about is something that happens so slow that it's really hard to actually tell. So you can have a couple of different types. We can have a conductive deafness, which is interference of the wave transmission in the external or middle ear. That's more of a mechanical issue. Or you can have a sensory neural deafness, which is a malfunction in the inner ear or the cochlear nerve. So a lot of times you'll see these, the operation where they put the sensor in the back of the skull. Have you ever seen that? Where they give people their hearing back. And that's bypassing the sensorineural deafness. It's really hard to get past the conductive deafness. Yes.
Is that the same thing as like a cochlear implant, or is that?
Yeah.
That's what
The
that,
cochlear implant is going to be more for the sensorineural versus the
but that's what that
conductive.
thing is.
Yeah, it's basically bypassing that area in the back. Equilibrium. When we talk about the other part of our ear passages, what they're doing, awareness and monitoring of the head position, right? So you basically, your body, again, the brain wants to know where the body is in space. This is monitored by the vestibular apparatus, the utricle, the saccule, and the semicircular ducts. Information is sent to the brain to help keep our balance. Vision and proprioception also help. What is proprioception? Yeah, basically our touch tells the brain where we are in space as well. So we have vision, we have touch, and then we have the head position, kind of all telling the brain what is going on in the outside world.
It's like proprioception, can't be word touching things.
Utricle and the saccule detect static equilibrium and linear acceleration. So basically standing and then moving forward in space. The semicircular detects angular acceleration. Yes.
For the equilibrium, you know, like football players, hockey players, myself included, with concussions.
Mhm.
Would this affect your equilibrium? Would the concussions affect your equilibrium?
Only if there is either a mechanical or a neural damage in the inner ear.
Mm.
Otherwise, it would have to be, that would be a brain issue. And that very well could be a brain issue, but then it would be actually inside the brain. So, the macula, receptor for the static equilibrium and linear acceleration. It's located in the utricle and the saccule of the vestibule, composed of a layer of hair cells, kind of the same system. And then, of course, supporting cells. The hair cells are going to have stereocilia and then one kinocilium projecting onto a gelatinous otolithic membrane, just like we had for hearing, right? The membrane is covered with otolith or calcium carbonate crystals. This is a little bit different. Basically, what's happening here is instead of getting waves that are moving the hair cells, it's just the bending of the hair cells as your head moves in space. So bending the stereocilia toward the kinocilium depolarizes the hair cells and increases their transmitter release. This then increases the impulse frequency on the vestibular part of the cranial nerve, and then of course the opposite reaction occurs if the bending is away from the kinocilium. So this is actually a mechanical movement, and it depends on where the head is moving, if it's moving forward or back. Yes?
I forget, I've already forgotten what the word is, but is that the fluid that's in there, is that what happens when you get vertigo? Is this the part that's affecting it?
Yeah, so basically with vertigo, you would be messing with this system, right? The bending of the
Hair cells aren't
hairs.
bending correctly or the right way.
Yeah, so here is what we're looking at along the inside. So you've got otoliths, which are basically just small calcium crystals sitting in this gelatinous layer, right?
Yep.
And the gelatinous layer is basically just kind of a medium to hold these up. And really, the only thing that's going to help them move or make them move is, again, movement of the head in a mechanical motion. So you have a sweeping of these hairs that's going to cause neurotransmitter to be released. So you have your kinocilium, the one main hair, and then the stereocilia. So if the stereocilia are going to bend towards the kinocilium or away, that's going to tell the cell how much neurotransmitter to release. All right, so if they are parallel, neurotransmitters released at the regular interval, and there is a steady rate of nerve signals. So basically to tell the system we are in an upright position. Moving the head back, you're going to bend those stereocilia towards the kinocilium. The hair cells are going to depolarize, increasing neurotransmitter release, and you're going to get an increased nerve signal. So you actually raise the signal when you tilt the head upward or backwards. When you tilt it forward, you're going to get hyperpolarization, inhibiting neurotransmitter release, and you're going to actually decrease the nerve signal into the brain. So, and really what's happening here is the gel is moving and literally moving those hairs either forward or back. All right, and again, this is for linear acceleration, right? So this is again forward and back, not side to side. So what is controlling side to side? Receptors for angular acceleration in the semicircular ducts, right? So this is a little bit different system. Let's try this. Here we go. So now we have side to side movement. When we're not moving, what is occurring? Really nothing, right? When we twist the head to the side, that's when we're going to bend those stereocilia and then increase the nerve signals into the brain in that manner. So again, it's the movement of this structure up here is what's causing the hairs to move. So a little bit of a different setup. I mean, instead of a straight fluid, which would be a little bit too easy to move, now we're looking at more of a stiffer type of material surrounding the hairs, so that you do really have to get that head moving to get those signals either amplified or turned down, depending on which direction you go. Equilibrium pathways, again, kind of the same thing, right? So the signals are going to be conveyed through the cranial nerve, and of course they are going to end up in the brain themselves. All of this information is going to be used to control basically eye movement and coordination and movement of the body or muscle tone, right? So if I'm leaning the head back, the rest of the body is going to need to know that we need to be ready for action, right? Because that's basically what's happening when you're leaning on the head back or leaning the head forward, is you're moving yourself in space and probably into, I would assume, some dangerous or more dangerous situations.